So as you can see across the mandibular anterior, the two centrals have tissue recession and exposure of the root surfaces themselves. So what we will be doing is using this graft to not only gain some tissue thickness, but also gain root coverage in the mandibular anterior. And this is the dermis, the Puros dermis tissue allograft itself. We normally take a size, cut it back to where we need as far as getting width on each side of the teeth to be treated with the material. And then what we will do is do some trimming of the material back just so we get a size appropriate for our defect to be covered. Once we get the appropriate mesial to distal width, I will just notch the dermis itself in approximately. I'll use a 15C blade, and this is important because what we do is prior to securing the graft, we will trim the normal emergence profile of the tissue into the graft. So when we reposition our buccal flap, the points of the soft tissue, such as you see here, will sit in approximately very nicely. And at this point, the graft is then rehydrated with non-activated platelet-rich plasma. And we are going to be using our Nd:YAG laser initially to do our frenectomy. I prefer the laser at this point because it's very localized, and when we go into incising the tissue and raising that full thickness flap, really the tissue itself is much easier to manipulate having a laser frenectomy done than using the blade to do this particular procedure. And you can see by releasing the fibers of the frenum that the buccal soft tissue is much less tense on the pull, the recession of the two mandibular anterior centrals. Broad-based frenectomy, the Nd:YAG setting is at a 3.0 level to accomplish this goal. So the tissue now will be much easier to manipulate and handle from a full thickness flap elevation. Now what we'll do also is mark our tissue. We're going to be making a mid-papillary internal bevel incision. And what this is important for is when we reposition our tissue, we will be preserving the crust of the papilla and then repositioning the buccal flap over this tissue. So this incision preserves the papillary heights of contour. And as we said earlier, we will then reposition this in a coronal fashion using the trunk of the papilla as the new bed for the dermal matrix and the buccal flap. Then go in with our GAR elevator, full thickness mucoperiosteal flap elevation, taking great care in this anterior region not to tear the very thin biotype of tissue that is present, and then reflection of the flap down to the base of the mucogingival junction. And completion of this then shows the exposure of the root surfaces of the two mandibular centrals, and also some recession over to the right lateral central. Now we're going to need to reposition this tissue in the coronal fashion. So a little bit further dissection of this tissue in the apical portion allows for some release of the tissue. Additionally, we'll have to go in with a 15C blade and release more into the flap itself to allow for further loosening of this tissue to reposition it more in a coronal fashion. And then with tissue forceps, moving the tissue in a more coronal fashion, you can see that we'll have tension-free closure after we reposition our tissue. And this is done as necessary to ensure further release of the tissue so that it may be repositioned in the coronal fashion. Same procedure is used when we get into our block grafting procedures to get tension-free closure, or any time that you need to be able to advance a flap in the coronal position. procedures such as this are required. Now, extensive root planing to remove any of the bacteria-infected cementum, roughened root surfaces to get down to the pure surface of the dentin is required. So that's what we're doing with a back action chisel. And by doing this, you usually create a notch at the cemento-enamel junction, which is a definitive stop for the graft once it is secured. Then, a burnishing of the root surfaces with citric acid pH of 1 solution is accomplished. And this really aids in two things, primarily for sterilization or further sterilization of the root surface itself, and then also to help open the dental tubules up for a better integration of the graft complex into the root itself for stability. So this burnishing of the root surfaces is accomplished for a minute or so. And once again, the main reason is for sterilization of the root surfaces. And then water irrigation to rinse off any remnants of that citric acid is accomplished. Now the Puros dermis tissue allograft has been sitting in a non-activated PRP solution for approximately 10 minutes, allowing the platelet solution to soak into the graft itself. Prior to placement, we will go in now, and the head of the papilla we will be dekeratinizing, so that as we secure our tissue graft and the flap to this, we will have non-keratinized tissue that can attach to the buccal flap we reposition. So we usually take a number 6 round burr and a high-speed rotary instrumentation and just go through a little bit of a dermabrasion to dekeratinize this tissue. Once again, that'll now open up so that we can have the flap secured to the tissue when we close. And you can do this with this, you can do it with the laser, you can do it with a scalpel. I prefer the number 6 round diamond. And actually getting a little bit more into the interproximal areas, this is a number 4 round diamond, just so we don't do any damage to the adjacent, a little bit more into the most coronal aspect of the papilla. Application of platelet-rich plasma activated now prior to placement of the dermis allograft. Our graft, which has once again been soaking in the platelet-rich plasma solution, is then inserted underneath the buccal flap and positioned approximately into the area where it will be secured. Now, initial stabilization of the tissue graft is done with 4.0 Vicryl Rapide and a sling suture to secure the dermis graft itself to the lingual aspect of the flap. We will start with one sling suture and then a continuous sling to secure the remainder of the graft itself. And this sling will help to tarp the tissue onto the lingual portion of the flap. Also, removal of the retractor is accomplished because of tension placed on the flap, and will go to a very light retraction by the assistant. And then our sling is continued to secure the buccal flap now to the graft itself and to the lingual portion of the papilla. And we continue to secure the buccal flap to the tissue itself by passing the suture material through the interproximal regions. We're also grabbing the graft and securing that with the buccal flap to the lingual portion of the papilla. Securing again the buccal portion of the flap to the graft to the lingual portion of the flap. And then just retracing our steps with the suture to make sure that the flap is secured. Now we'll be just tying off the end of our suture at this point. And then checking our tension-free closure again, And you can see that there's very little tension now on the soft tissue between the 24 and 25 site from our release of not only our flap, but our release with our 15C, and of course the laser frenectomy that was accomplished earlier. Now I'll be putting in pretty much just one stay suture to help keep the base of the frenectomy together, and also to control some of the postoperative oozing that might come from this opened portion. So just reapproximation of the two portions of the incision site will accomplish that goal. And you can see the stabilization now of the buccal tissue. Application now of platelet-rich and platelet-poor plasma over the surgical site to help with tissue healing and maturation is accomplished prior to dismissal of the patient. And here is the application of the platelet-poor, which is this bioactive wound dressing that is usually accomplished post-operatively prior to dismissal of the patient.